welcome back to Professor Colleen Aldous, all the way from South Africa. Professor, thank you very much for coming back on.
Thanks for having me again, John.
Now, you and me have been talking about this for some time, and I've been looking forward to this video. We've got this fossilized, stereotypical idea about what we call the hierarchy of evidence. Now, just before you click off this video, it's not academic, it's not esoteric, it is highly relevant, because this determines the treatments, the medical treatments and the medical interventions, the health interventions that are available to us all. So we need to move away, at least Colleen is arguing, and I agree with her obviously, that we need to move away from this rigid hierarchy of evidence that we've had in the past onto a more progressive, modern way of looking at it, so that research which arises from the grassroots and evidence that arises from the grassroots, as opposed to evidence that is paid for by rich individuals or rich institutions, we need to have that balance. Colleen, I think that's what this is about, Colleen. But if you start us off with the existing hierarchy of evidence and what is wrong with it, please.
Okay, thanks, John. Everybody at medical school has been taught about evidence-based medicine over the past 30 years. It's become a part of the curriculum. And in that process, they have been taught that various types of research are good and other types of research are not good. And so there's been this hierarchy that has been created. And a diagram, the hierarchical pyramid was created after 2000, and alongside that hierarchy there was put an arrow that said quality. So there was a misconception created that so many people have gone on with for decades now, that the higher in the hierarchy a study type is, the more reliable it is, the more you can make an inference from it, and the lower down it is in that hierarchy, the more worthless it has become. And so that has been known as the evidence of medicine pyramid, and that's given rise to what I've now called pyramidal thinking or gold standard thinking, because from that has arisen the statement that gold standard research is a randomized controlled trial. That's the gold standard. And randomized controlled trials and their meta-analyses are the only types of studies that are worth making a clinical decision on. Beneath the randomized controlled trial in the pyramid are ordinary case controlled trials. We've got observational trials, we've got case studies, we've got laboratory studies, we've even got opinions, and that has been dismissed as either anecdotal or of insufficient evidence. And that term insufficient evidence has become very widely used throughout the pandemic. And the pandemic taught us to start questioning this approach.
Yeah. And of course, the randomized controlled trials that are at the very top are remarkably expensive. Normally it's particular rich individuals or particular rich institutions or particularly rich corporates decide what they're going to research. And very often one suspects, or there's a risk, that the things that are researched are the things that are going to turn a tidy profit, thank you very much, rather than things that are necessarily going to benefit the millions of us poorer people around the world. And if people are deciding what randomized controlled trials to do, of course they can decide what randomized controlled trials not to do. So potentially efficacious treatments that are inexpensive and cheap but aren't going to be profitable may not be analysed using this randomized controlled trial methodology. Would you share that concern, Colleen?
Absolutely. I think that industry is able to support randomized controlled trials. And frankly, John, I would not take a novel drug today if it has not gone through a randomized controlled trial from the pharmaceutical company that has developed it. It makes absolute sense. If I was going on to a novel diabetic drug, for example, or a high blood pressure drug, I would want to know that it's gone through a randomized controlled trial. However, they've used it as a kind of propaganda to say that that is the only type of trial that is worth making an inference from. So, for example,
it's an important point. Let's just clarify that, Colleen. You and I are medical professionals. You supervise doctors all over doing research. That's what you do. And we're not saying that randomized controlled trials are bad. We're saying that they are limited and they are selective. And they shine a light on a particular area, whereas we'd like to light up the whole countryside, ideally. So we're not saying it's bad. We're saying it's not adequate. Is that, I put that crudely, but is that roughly right?
It's not adequate in certain circumstances. For example, in a pandemic situation, when you've got to make decisions on the trot, when you're at the coalface and you have to make a decision and you've already got background information. So for me, I'd say randomized control trial with a novel drug, very important. We've got to do that. But what's happened is there's been this propaganda to say it's the only kind of research that counts. And in fact, when we were writing the paper, one of my co-authors came across a statement in a medical textbook that stated if a drug has not, or if the study has not gone through a randomized control trial, he's not prepared to even look at it. However, if you have a look at all the kind of observational studies, case series, laboratory-based studies, in silico studies, there's a whole lot of information out there that makes us understand how this drug works or does not work. But my favorite story about randomized control trials, seeing as everybody is now saying randomized control trial or bust, is the one that was published in the British Medical Journal several years ago about parachutes. It was by Smith and Pell, who said we should get an experiment going where we test the efficacy of a parachute against trauma induced by gravity. And so what he would be saying is we're going to have some people up in the air with a parachute on and some with just a bag and no parachute, and we'll throw them all out and see who survives.
And until we have the evidence, we should stop using parachutes, because we've no randomized controlled trial that shows that parachute use saves lives. That was a joke, by the way.
Yeah, exactly. So yes, that's Smith and Powell, where we're making this point just to show how ludicrous it is to always rely on a randomized control trial only, especially when there's so much other evidence available. Mm-hmm. And in fact, with parachutes, you can just use your common sense. And they go on to say that those people who really support randomized control trials should then back a crossover study, which means that those people who had the parachutes the first time round don't get them the next time round. So they'll get the placebo bags the next time round.
Yeah, we could put a few parachutes onto corpses and throw them out of aeroplanes. Quite how they'd pull the ripcord, I don't quite know. But yeah. Anyway, serious matter. This is your paper here, Colleen. Just yes. Introduce us to the idea, wheel replacing pyramid.
So during the pandemic, I came to the realization when people were saying insufficient evidence all the time about some of the repurposed drugs, I realized that there'd been a complete misunderstanding and misconception of David Sackett's evidence-based medicine. And the more I heard about insufficient evidence, the more I was putting the evidence together, and I was putting out a pyramid every week into the onto the WhatsApp groups I was in, but I was preaching to the converted. And eventually I realized when our regulatory body said there was insufficient evidence, and I kept looking at my pyramid to say, but there isn't insufficient evidence. We've got evidence right from laboratories all the way through to meta-analyses. And I realized what they were saying was they didn't have the randomized control trials that they liked. So it's not only just randomized control trials, they had to be randomized control trials with hundreds of people involved. And just to provide context, at the beginning of the pandemic, I tried to get a randomized control trial going for a repurposed medication. And the quote that I was given was 20 million rand, which translates into around £1 million or $1 million.
Did you have that money spare?
Oh, yeah. You first, to try and get that kind of funding was absurd. It's not,
Yeah.
but I keep thinking how unnecessary it is when we had laboratory studies coming out of Australia with Cayley's paper that initially got the interest going in one of these repurposed medications, and we had several people talking about wards that they'd worked on. So there were observational trials. There were some randomized control trials with smaller numbers, so under 200. And the other thing that people were saying was, but look at where they're coming from. They were coming from places like the Middle East or in Indonesia. So, I mean, that's just plain racist. It's snobbery of the worst kind. So what I realized was people were not looking at the evidence, and they were not interested in looking at the evidence. And I came up with the idea of taking that whole hierarchy away and presenting the data in such a way that you could see the picture of all the data that has come together. So when you've put the data...
Yeah, I was just going to say, yeah, that's illustrated really nicely in your diagram here, Colleen.
Yes, so what we've done here is we've taken away the hierarchy. There's no more quality. In fact, that quality error is erroneous. That quality error should say certainty, because yes, there is more certainty in a randomized control trial than there is in a case series. But it isn't necessarily better quality. You might have a very good quality case series and a very bad randomized control trials, and we've seen them. I'm busy with some colleagues analyzing some very bad randomized control trials at the moment, but I think to get that covered. So what we did with creating the wheel is we took all the studies that were in the pyramid, plus we added other kinds of studies that were totally ignored by the traditional pyramid. And that would include studies that give you an idea of what the mechanism of action would be. So to my mind as a scientist, I'm not a clinician. I'm a scientist. I trained from the beginning, since I was a teenager, as a scientist. And my way of thinking is, if you see something happening in a patient and you can explain it from what happens in the laboratory, that makes a lot more sense than just having a randomized control trial. So if you start combining different kinds of information and coming up with truly scientifically logical conclusions, you're going to come out with a better decision. And so that is what we started doing. We started looking at all the evidence. So that's the totality of evidence wheel. And if you go back to what Sackett said, Sackett was saying we've got to look at all the evidence, and amongst that, the best available evidence. And he didn't say the best available evidence was a randomized controlled trial. At some point in 2020, the best available evidence was a couple of cohort studies and some laboratory work. That was enough, if you did your homework on some of the repurposed drugs, to find out their safety profiles, to make a decision to try things without necessarily having to go through a randomized control trial.
And of course, this consistency between the laboratory findings and the real world findings, the theoretical, the bench findings, and of course now we can add the in silico work, comparing and contrasting that with the real world is exactly what Austin Bradford Hill and Richard Doll did in the 1950s to work out that smoking caused lung cancer, and later on to show that smoking caused arterial disease, and later on to show that asbestos causes mesothelioma. And this predates Sackett by several decades. So this tradition of logical thought is well established, and you're carrying it on. Maybe just unpack this wheel a bit for us, Colleen, please. So you've got structured. But where would you like to start? Shall we start with mechanisms of action?
Okay, so we divided the totality of evidence into 4. So we've got the mechanisms of action, and that is where we'll get an understanding of how a drug works. And that would come through in silico studies, which we have today. Those weren't around, haven't been around forever, but with AI, in silico studies can be pretty good these days. Then there are also in vivo studies, seeing how drugs worked in animals. And we have seen the
in vitro as well, where we may be taking cell cultures.
That's right, and that was, for example, in one of the repurposed drugs in 2020, there was a lot of excitement around about April from Australia, where Cayley et al. Showed that in a petri dish, this drug actually killed the virus. That paper was maligned by so many people because they misinterpreted the results completely. All that group did was say, we took petri dishes, we treated the petri dishes that had the virus with these drugs, and this drug killed the virus in that petri dish. They never spoke about how much of a concentration has to be given to a human being. It was an in silico study. So what do we get from that study? We get that the virus cannot survive when that medication is added to it. So we need more research. But what happened was that research was dismissed. And people were saying the concentrations were too high, you can't use those but that was never the issue. But it's almost like people deliberately wanted to misinterpret the data.
Imagine
so
that,
we have,
really.
Yeah. So, and there were other lab studies. I've been involved with David Scheim from America. He's an ex-MIT scientist, where we looked at partly in silico and in vitro to be able to show exactly how the spike protein is affected by a repurposed medication. And that publication is out in the public domain as well. And that explains exactly how come a patient who has got a very low SpO2 or blood oxygenation saturation can improve within 12 hours, which is what we showed in the data we worked with Jackie Stone, etc. In the Zimbabwe data. We showed that her patients arrived, and the minute she put them on this drug, within 12 hours, their oxygen saturations had improved, many of them to within normal ranges. So we can explain that by an in vitro study.
And what the pandemic has really done, and the good thing about the pandemic is it's brought to light all of these challenges, difficulties, because we've got other diseases, malaria still killing so many thousands of children a day, I think, in Africa still. We've got cancers all over the world. We've got other bacterial and viral infections. We've got a whole range of diseases, and we need to bring the whole weight of this method of analysis to look at these diseases and start coming up with real world treatments. It's so important. So that's mechanisms of action, which of course is very important. What should we do next? Should we do non-structured, non-systematic reviews next?
Yes, so non-systematic reviews are the kinds of reviews that you get very early on in a pandemic or early on in a health occurrence. So these are people who in 2020 started looking at all the literature on repurposed medication, and they came out with reviews. They were not structured reviews on randomized controlled trials, but they gathered the literature and they said, from this literature that's already been published, we can understand how this particular drug could have potential to work in a pandemic. So a lot of people took a lot of trouble to do the research, the desktop research in the beginning, and that research was just dismissed as insufficient evidence or anecdotal. I actually find it very difficult to accept the definition of anecdotal by some regulatory bodies, because I think we know in English anecdotal means the odd occurrence here and there, whereas when something is happening at the same time across the globe, the same results are coming out, that's not anecdotal. If we compare Peru, who had a regimen that had a repurposed medication, and we look at Uttar Pradesh, a state in India that had a very similar regimen that they handed out prophylactically, they came out with the same results. Nobody organized that across these two countries there was going to be some research to show that this drug did or didn't work. But when people wrote those kind of studies up, they were dismissed as being anecdotal. Anecdotal when you've got thousands of people, I don't accept that. To me, when it's happening,
Anecdotal to me means anything I can't make money out of.
that's what it's become, I think.
Or in an argument down the pub, anything I'd like to disagree with.
Yes, yeah. And if you're going to push the RCT agenda that only RCTs count, then yes, everything else that's not a randomized control trial is anecdotal.
Yeah.
Yeah.
Clinical studies, Colleen, what's your thinking there?
Okay, the clinical studies are those that start to make regulators stand up a little bit. So in clinical studies, what we have done is we have put together everything that they regard as gold standard, as well as anything else that happens in the clinic. So this is where the patient is actually taking the medication, and those results are being reported. So, for example, there might have been a home for the aged where one floor was given a drug for scabies, for example, and that floor nobody got COVID, but every other floor it got those patients got COVID. That kind of thing we would count as a clinical study because it was patients who had that, who got the drugs. It also get your randomized control trials, even those randomized control trials that were designed to fail. And we are looking at those in more detail. There's one in particular where I asked for a mortality figure and it was refused. The one of the authors I spoke to said it was a stupid question to ask. But when I did the maths, I showed that their randomized control trial where they state that this drug did not work actually had a pretty good efficacy when it came to preventing death.
If it is that some people around the world are using randomized controlled trials that are designed to bring about a predetermined outcome, that is the antithesis of science.
That is exactly true. And that is, we saw that happen. But I think what's coming out now post the pandemic is there's been a lot of antithesis to real science. A lot of people who called themselves the science, who said they were the ones to be the only ones heard because they were such great scientists. If you have a look at their backgrounds, they've profited a lot.
The arrogance, and during this pandemic, really strange things happened to me, Colleen, that leading scientists around the world, and I know you wouldn't accept the accolade, but I would certainly include you in this, leading scientists around the world, leading doctors who have talked to, in talks informally, have worked with some of these people that have now hit the stratosphere. And it turns out that quite a few of them weren't very impressive at all. They weren't very good doctors and they weren't very good scientists. They were promoted up the way.
And not people you could have a discussion with easily. To me, if scientists can have a discussion and disagree, and the aim in the discussion and amongst the disagreements is to try and find out what is causing a disagreement to come to an ultimate scientific truth. Whereas many of these people we're talking about now just dismissed anything that opposed them. It was just a clear dismissal. There was no approach to negotiate science further to see where we could get to a truth. Yeah,
absolutely. So clinical study is very important. And you mentioned, for example, I mean, I think we can talk about this drug. The drug we're talking about, of course, the case study that Colleen has done is ivermectin. It's a repurposed drug. It's dirt cheap. It's got a remarkably high safety profile, and I've seen it work, and Colleen's seen it work, and the doctors that Colleen supervises have seen it worked in different situations. So anything else to say about clinical studies, Colleen?
Yeah, we can. If there's some arguments about clinical studies not having any certainty, I've been working on a paper not yet published where we've compared 3 different studies that were independently carried out across the globe. The authors didn't know each other at the time. And I've been working with a mathematician on this paper, and we're able to show mathematically that it is impossible that ivermectin did not work to reduce mortality. So we're hoping that, but getting that kind of thing published even today is very difficult, because what we had during the pandemic was also a veto against anything positive against any repurposed drug.
Yeah, I mean, if different people are having the same idea on different continents completely independently, substantiating it in similar ways, to me that's a pretty good indicator that it's probably a good idea. I mean, we think in the history of science where we had Isaac Newton and I can't remember who it was now, some other mathematician inventing calculus at the same time. The name we've got Charles Darwin and Alfred Russel Wallace both coming up with the idea of natural selection at the same time, independently. Quite interesting, and we'll get all the physicists telling me who this mathematician was. So apologies for my poor memory. Structured analysis, Colleen.
So these are the studies that people have said are almost better than the gold standard. So you take your randomized control trial and you do a meta-analysis. And in the ideal world, this is true. If you're able to take a whole lot of studies and put their data together and come up with a new analysis of the results, that would be true. But if you've got randomized control trials that were not properly designed and gives you results that are not really reliable, i.e. the randomized control trial is not good quality, then your structured analyses are also going to be fake. They're not going to give you the real answers that you're looking for. And we saw that. There was a very good example during the pandemic where one highly experienced scientist created a systematic review on ivermectin, and then another person, also experienced, came up with another review. The two reviews came out within days, I think, of each other, almost with identical titles, and they came up with opposing results. What does that tell you? It tells you the science went wrong somewhere. Somewhere along the line, the objectivity went out the window and subjectivity crept in. So when it comes to structural analyses, I'm afraid I have become a little bit more cynical about how reliable they really are.
Yeah, I've been a bit more cynical now as well. Rather than subjectivity creeping in, I was just hoping that it wasn't subjectivity injected forcibly into that situation. But let's hope that wasn't the case. The wheel is egalitarian, isn't it? You know, it's all kind of even. Any aspect of evidence can potentially have equal weight depending on the situation, how it's argued, how it's applied, how the evidence was generated, and the effect it has in the clinical situation. Is that roughly true?
Yes. So when you're looking at a wheel just like this, you cannot tell good from bad studies. So you can have some randomized control trials that are good and some that are bad. But if you go to the next diagram, the case study diagram, which is a little further down, the wheel that shows what we did with ivermectin, what we get here is a picture of where the data sits. We're not getting a picture of the quality of the data. So this picture now shows you that on the 30th of September 2022, we had about 265 papers on ivermectin and COVID, all published in PubMed journals. And we put them into a third wheel around this wheel, where we showed in the green those papers where the discussion and the conclusion of the paper was ivermectin had a positive impact in a COVID-19 patient sufferer. The red showed that it didn't work at all. They didn't get good results. And the yellow showed results, the discussion results, where the author said more evidence is required. So it's not either a yes or a no. So what you can see from this wheel is there seems to be a balance at some point 18 months ago between papers that said there is a positive outcome and those that said there is a negative outcome. A lot of those yellow articles, when I read them, showed that ivermectin was going to work, but the authors had to step back and say we only had a sample of 40 patients, so we need to do more research. But the point at this level is to show you that there's evidence for and against. What a regulator would have to do now is actually go and look at the quality of some of those papers. Whether the regulator will do it properly or not is, debatable. But
it probably depends who's paying the regulator as well, doesn't it?
Yeah. But what's interesting there is you can see that in the systematic reviews, nobody was going to publish anything that showed that ivermectin worked.
Zero, yeah.
Whereas there were clinical studies that showed that it worked. There's definitely mechanisms of action that explain how it works. And there were some people at the lower reviews level who were also talking about the fact that ivermectin worked. So as a regulator, you could step back now and say, there seems to be a balance between positive and negative. We never ever saw that during the pandemic, right from scratch, I would say it hit a peak in 2021. There was a propaganda campaign against the use of ivermectin. We had that American campaign when they said, "You stop it now, you're not a horse, you're not a cow." I believe that has had to be admitted to being incorrect, and it's been removed. But there was an absolute campaign against it, whereas the real data in PubMed was showing a balance. The real science, not the science as it was interpreted by whoever didn't want to see ivermectin. The real science before a strong embargo was showing that there were places ivermectin definitely was working. Mm-hmm. And had we stuck to those true scientific principles, we would have had a much more humanitarian outcome to the pandemic than we ended up having.
And given time, Colleen, you could do this for any treatment, really, couldn't you? I mean, whether it was statins or whether it was, I don't know,
absolutely
blood pressure medication, or maybe looking at artemisia for treating malaria, or basically anything you could do this on.
Well, what I would like to see is that this idea gets taken forward by other thinkers. I would like to see people taking this and applying AI to it to make it, to have maybe a website with various medications with a live updating of data all the time to show how medications, how the research in medications is developing, so that further research will be better informed, and also how treatments will be better informed. Artemisia, for example, if we started looking at all the literature, if we could put it into this kind of a wheel, we might be able to say, yeah, let us try it. Whereas I have a feeling that industry might not like that.
Well, we know people can grow it in their backyard, and we know it won the Nobel Prize in 2015 for management of malaria. So that's a small intimation that it might work. But because people can grow it in their backyard, they don't need to go to the pharmacist to buy it. So maybe, who knows? That could be one of the reasons why it's not been promoted. Who knows? Would this model work against or work for? We're talking about treatment specifically here. What about preventative strategies, health promotion strategies? So suppose I wanted to look at, say, prevention of dementia or prevention of arterial disease in the heart. I mean, do you think this model could work for that as well?
I think that more thought would have to go into it, but if there is existing research can be put into a wheel like this, and you can create more than the extra one wheel that we have created. You can start looking at what were the outcomes in patients with combination therapies, not just therapies on their own. We can start looking at who's done research in the laboratories to see, has this worked? Has this worked on mice and rats or monkeys? Has this have there been some clinical outcomes in integrative medicine that we can investigate and add that to this wheel? So I think this wheel can be adapted to many therapeutic outcomes or decision-making strategies. You just have to put the thought into it. Mm-hmm. And a lot of people don't like to do that. But I really think...
Well, a lot of people aren't paid to do that, perhaps more to the point. Or some people are paid not to.
I would like to see the first place where this is used is by the WHO, looking at their essential list of medicines. To have a real life.
Sorry, I'm sure they're watching now, Colleen. Yeah.
Yeah. to have
oh dear. Yes.
Medicines on a website where you can actually monitor what's happening in those areas. Yeah,
I couldn't agree more. Let's hope we see these. So this wheel format analysis could be used for any of the essential medicines. Now, of course, a lot of the WHO essential medicines are essential medicines. Ivermectin is on the list. There's no question that many medicines are essential. It's important to realise that we are not trying to dismiss all of conventional medicine. Not by any means. It's brilliant. It saves so many lives. But things carry on and a bit's added, and things carried on as a bit's added, and we end up with a bit of a topsy curve, and we can get away from the original evidence base. So at any point in time, you could say, well, just a minute, let's take this treatment. Doesn't matter what it is. Let's say it's childhood vaccinations for MMR or whatever it is. Let's take that. Let's plug all the information we've got into this wheel, and let's use that to increase our objectivity, the objectivity of our analysis.
That's right. Yeah. It's exactly what it will do. It'll give you a picture of everything that is there. Yeah. Your quality analysis still has to come.
Yeah. I like to think Sir Richard Doll, Sir Austin Bradford Hill, and David Sackett are nodding along to this video, Colleen, because it is completely consistent with this wonderful epistemological tradition that we have of evidence-based medicine and proper analysis, and it really is the antidote to some of the less rigorous thinking that we've been subject to, perhaps in recent years. So fascinating work, and let's hope this is taken up more and more, and really good basis for a PhD, isn't it? So PhD supervisors around the world could say, look, you're analysing this particular intervention. Try a Colleen Aldous wheel on it and see what you come up with.
Yes, I really would like to go into further discussions with other thinkers on this wheel and develop it further, because currently this is the thinking of me and 3 co-authors. It really does need more discussion. And actually, you've also contributed to it, John, the thinking behind it.
I don't think so, Colleen, but it's kind of, I've publicised it a little bit maybe, but that's all. My job's dead easy. I just talk to clever people. That's.
But you've spoken to clever people who are thinkers, who are pointing out things that should not be happening, that are coming from somewhere where none of us, we've been blindsided in the pandemic era in the last few years, but we never expected it to ever come to us the way it did.
Yeah, I mean, I agree 100% with that, but I think it's been longer than the last 4 or 5 years. I think this has been happening for some time, but the pandemic has brought it into sharp focus. Which is one of the good things about the pandemic. But for now, Professor Aldous, thank you very much. Fascinating, and do leave a comment. Do let us know what you think, and if you're in a position of power, who knows? Maybe you're in a regulatory body. Consider using this wheel as an evidence analysis tool. For now, thank you for watching.
Thank you.